Welcome to The Blend, a new podcast brought to you by the Journal of the Dermatology Nurse Practitioners and Physician Assistants. The Blend takes a deep dive into the expanding role of integrative dermatology, an approach to skin health that blends conventional medical dermatology with complementary therapies to address symptoms and underlying disease factors. In this four-part episode, Dr. Sonal Choudhary, a dermatopathologist, dermatologist, and director of the Integrative Dermatology and Skincare Clinic at the University of Pittsburgh Medical Center, and Natalie Gardinier, MPAS PAC, a Dermatology Physician Assistant at the University of Pittsburgh Medical Center Dermatology, take a deep dive into integrative approaches to treating acne. Part 1 of this episode looked at the etiology of acne and the important role that cleansers and topical therapies can play in treatment. In Part 2, our experts will review oral acne therapies, including probiotics, and discuss the importance of incorporating sunscreen in every acne patient's treatment regimen.
So now that we've touched on all of our topicals, typically the first line therapy from an oral standpoint is going to be those antibiotics. So we start with our doxycycline most often, tetracycline class antibiotic. However, a lot of patients are not able to tolerate this. Maybe it's contraindicated. And so sometimes we'll even go to a macrolide antibiotic like azithromycin. But ultimately, these antibiotics have really great antibacterial properties, of course. They're reducing that C. acnes on the skin, but they also have anti-inflammatory benefits. And so patients who have these really firm, maybe tender nodulous cystic lesions, it's helpful even just for pain relief. One thing we do in practice, and I think it's important to clarify this for our patients, is we use these antibiotics very strategically. We're really just helping to kind of kickstart somebody on their acne journey, because when they come in with really significant inflammation, lots of red, angry papules, pustules, it can be overwhelming, right? Trying to rely on topicals alone. And so we'll use a short course of antibiotics, maybe doxycycline, to calm down that inflammation quickly. It's not a long-term solution, but it really helps to kind of create a window where the patient's skin is maybe less inflamed, a little bit more stable and receptive to their topicals, so that way they can then kind of maintain those results over time. And then we always talk about this idea with our patients of this antibiotic stewardship, right? Like using them for the shortest effective duration, almost always just a couple of weeks, maybe 2-3 months max, but even then it's a bit of a long course. And then we really like to build a sustainable kind of long-term plan with topicals at the same time, adjusting some lifestyle things and other systemic options if needed, so that they're on a solid regimen going forward.
Yes, we are very strategic with antibiotics. You're absolutely correct. I know that within dermatology, there's a lot of data with use of antibiotics, different ones. I think we also have Bactrim on that list for use in acne. However, just because we have these options, often that should not be used very long term. I see patients come in and they have been put on antibiotics for 6 months, a year. I have patients who have been on antibiotics for more than 2 years. That is just not how I think antibiotics are designed to be used in even this chronic, as a chronic condition, as an anti-inflammatory, or for that matter, for actual bacterial, changing the bacterial nature. So that is very important to know, like how we are talking about it strategically here. Always keep that in mind. And it should be, like you said, it starts the journey, but where's that journey going? So in an integrative thought process, it's like we have to explain to the patient. And the best part is with the integrative process that we are following, we are maybe attracting patients like that who don't want to be on antibiotics that long. So it helps both ways. If we were to pick an oral antibiotic, I want to highlight sarecycline. So sarecycline is also, as the name suggests, a tetracycline class antibiotic, but it has a much more narrow spectrum of activity. And when you compare it to our other, available tetracyclines like doxy and minocycline, it has a little less activity against the intestinal gram-negative bacteria. And I'll give you the data on that from 2018 clinical trial. They used it, it's a once a day dosing, so that's another great thing. It has a weight-based amount that's 1.5 mg per kg. This dose reduced significantly the inflammatory lesions in moderate to severe facial acne in the patients that they had in the study. And it was tolerated super well, and the side effects were like much, much better than other tetracyclines. And one of the things about sarecycline is why probably it does this is because it has this minimal and very transient impact on the gut microbiome composition. And it does not impact the diversity of the gut, which is such an important thing to remember compared to the amino and doxycyclines.
Yeah, while we're on the topic of the gut microbiota, making sure that things are healthy and stable, I would like to touch on probiotics.
Probiotics are living, gut friendly bacteria that can benefit our overall well being. These organisms may be found in fermented foods like yogurt or high quality supplements.
Probiotics have a really early promise for use in acne. And the key here is that probiotics are very much strain specific. So they're not all created equal, but when you find the right one from a very reliable source, it can be helpful in reducing inflammatory lesions. So there have been a couple of key studies that show this. The first is in adjunct to oral antibiotics. The second is just on its own as a probiotic. And then the third is in combination with a botanical extract. So I'd like to kind of dive into these studies. The first one being a 2013 randomized control trial by Jung et al. It found that patients who took probiotics as an adjunct to their minocycline actually had a significant decrease in the total lesion count as compared to the patients who were in the control group. And this was after only about 8 and 12-week follow up. So, pretty significant in terms of timing, pretty rapid onset here. There was another study, 33 patients with acne in 2019, found to have an increased level of their IL-10, which is an anti inflammatory cytokine. That was with a probiotic alone. And these levels were taken after only 30 days of treatment. So, again, fast acting. And then another recent study, 2022, investigated the use of probiotics in combination with a botanical extract. This extract contained lupiol and melangina. It's a blend of botanicals that was combined with these probiotics, and they found pretty significant increase in, again, that IL-10, reduction in superficial inflammatory lesions of these patients, decreased desquamation score, sebum secretion rate was decreased, and then the porphyrin counts in these groups were also decreased as well. So make sure again you're getting these from a reliable source, but really great adjunct for your patients with acne.
Yeah, the strain is everything, and whether when they are looking at these things in the studies, most importantly, whatever has been studied in a research, that exact strain should be present in the product that is being sold in the market for that particular indication. So these are not medications. Probiotics are not drugs yet, anyway, and they are still have very the potential for being very targeted. But we need to understand like how their use and application has to happen. So it is not really one size fits all. However, strain is the key factor to remember. I want to go into sunscreens a little bit because sunscreens are something that is part of every regimen we talk about for our acne patients, especially. They're using all these products and components in the regimen that we have prescribed to them. They must protect their skin from the sun so we can keep all those benefits, right? And overall, sunscreens are divided into chemical blockers, physical blockers. The chemical blockers usually are these organic sunscreens which absorb ultraviolet radiation and then dissipate it as heat, while the mineral ones or physical blockers are inorganic sunscreens which will absorb the UV radiation and scatter or reflect it. So what should we recommend for our patients? Again, nothing is like one size fits all, but a broad spectrum in general for someone who is not complaining of any issues using sunscreen in the past or has never really tried anything. A broad spectrum, preferably even water resistant sunscreens, because we don't know where their activities are going to be. Often people think of sunscreen on the beach, so might as well have water resistance to it. With a sun protection factor or SPF of at least 30 is recommended, right? But if you're talking about a very light skinned person who easily burns, 50 is a better number, sometimes a bit higher. One should apply it 15 minutes prior to sun exposure. If you want your sunscreen to do the job, you have to apply it 15 minutes before you are actually exposing yourself to the sun. And then every 2 hours or so, that reapplication must be done. If you're not reapplying it, that sunscreen's gone. So we cannot really, really rely on that. And if they're especially sweating or swimming or any kind of water sports, that becomes even more important. Less reliable, quite kind of less reliable to stay with that original application. One more thing I want to add here is HelioCare. HelioCare is a product that has been around for some time. It actually has polypodium leukotomas in it, which is not a full sunscreen in itself. So we never recommend that our patients just take that as a pill and forget about buying sunscreen. It's more of an adjunct for people who burn easily and who are going to be outdoors. It's unavoidable for them because it's a vacation or travel. And sometimes adding that on for someone, say, who's on isotretinoin treatment, etc., is going to be very helpful.
Yeah, those are great points. I always tell patients with acne prone skin or just inflammatory skin disease in general, physical blocker sunscreens or those element sunscreens are going to be best for them. They're less likely to react with the skin and become comedogenic. And a lot of these sunscreens can be easily identified. I tell patients look at the first ingredient on your sunscreen. If it has zinc oxide or titanium dioxide, a lot of these newer sunscreens are now even featuring ingredients like iron oxide and even supplemental antioxidants. That's the best way to identify these element sunscreens. Now, iron oxides are pigments. They can be used to create actually a tinted sunscreen. So a lot of patients like these because they're almost like a good little everyday makeup. It's a light makeup, but they also provide better protection against visible light, which is nice. So for those patients who are primarily prone to hyperpigmentation, maybe skin of color patients, or those who suffer from melasma, these are some really great options for them. And then another cool feature with a lot of the newer sunscreens is these added antioxidants. A lot of them have like vitamin C's and E's, and these can boost the photoprotective function of the sunscreens because they're kind of combating oxidative stress that's associated with sun exposure. And so these can, with time, help to reduce, obviously, the potential harmful effects of potential harmful risks of sunburn and the other harmful effects of UV light, such as aging.
Yes, thank you, Natalie, for talking about that visible light because we often don't think about that. That's not a traditional way of thinking about UV exposure. Visible light is a big spectrum component as well.
We hope you enjoyed part 2 of our 4-part episode on integrative approaches to treating acne. Thank you for listening to The Blend. We'll see you back next time.